Hi everyone. Welcome to today's webinar on lower extremity nerve blocks presented by Dr. Caitlin Bailey. At the conclusion of this webinar, participants should be able to describe the indications, regions of anesthesia, and techniques for featured nerve blocks. The AIUM is accredited by the ACCME. This webinar is designated for 1 AMA PRA Category 1 credit. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. Participants who complete the post-test with a grade of 70% or higher will be awarded 1 CME credit. As an ACCME accredited provider, it is the AIUM's policy to ensure that the contents and quality of this activity are balanced, independent, objective, and scientifically rigorous. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to an activity. Dr. Bailey has no disclosures. AIUM staff members and individuals involved with planning this activity have no disclosures. During today's presentation, if you have questions for the presenter, you may type them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenter will not begin answering until the end of the presentation, at which time she will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now, we're pleased to present Dr. Caitlin Bailey.
Hi everybody, thank you to AIUM and to Kathy for helping coordinate this. I'm Dr. Caitlin Bailey and I'm an emergency physician in Oakland, California at Highland Hospital. My hospital is a trauma center and an emergency medicine residency training program, and we also have an ultrasound fellowship. So we do a lot of ultrasound and we do a lot of nerve blocks. So I'm going to be speaking to you today about lower extremity nerve blocks, targeted pain control for lower extremity injuries in the emergency department. Certainly I'm an emergency practitioner, so I'm going to be speaking about the types of injuries and conditions that might be amenable to nerve blocks in my setting, but you could easily extrapolate this to other settings as well. So the goals of this talk are pretty straightforward. So we're going to be describing the lower extremity emergencies that are amenable to nerve blocks, and then I'll get into kind of the nitty-gritty of the techniques. So we'll be specifically discussing the femoral block and fascia iliaca block. There's a subtle difference between those two, but both terms come up in the literature, so I'm going to be speaking about them both. They're going to target the same areas and same injuries. The distal sciatic block, colloquially known as the POP block, because you start in the popliteal fossa to localize this nerve, so that'll be a distal sciatic block. And then an ankle block of the posterior tibial area, so it'll be the tibial nerve at the ankle. So that's referred to as a posterior tibial block. And then a saphenous block as well. Presumably, if you are signed into this webinar, you have more than a passing interest in nerve blocks, and so you may not need to have the reasons behind it explained to you. You may be perfectly signed on to the idea that you're going to learn to do these techniques and perform them, and I hope I can help with that today. But you, depending on your practice setting, you may be having conversations with administrators or consultant services such as trauma or orthopedic surgery about why practitioners in the emergency department or other settings might need to be doing these nerve blocks and whether they're safe and what's the value added. I think there's a lot of value added. That's obviously kind of why I'm here today. And it's for a couple different reasons. One is just multimodal pain control. We know that we don't necessarily do a good job of controlling patients' pain for acutely painful conditions, but there's also a risk associated with high-dose opiates and an opiate-only approach providing multimodal pain control is a worthy goal in and of itself. And some conditions here are going to require procedures such as reductions of fractures and dislocations that in many settings occur under procedural sedation. However, my hospital is frequently operating essentially at capacity or beyond in the emergency department, and getting a patient into a room capable of performing a procedural sedation with the staff required for that can be very challenging, and patients often wait hours to move into a procedural sedation capable room. So if the condition could have its procedure, usually a relocation in this setting or a reduction of a fracture, without procedural sedation with good pain control under a nerve block, you really save yourself and the emergency department a lot of time and resources, and it's good for the patient. And then other people may be functioning in practice settings where they're in more austere settings and they don't have an orthopedic surgeon available, and they may be transferring a patient in a long ambulance ride or on a helicopter, and you want to provide good pain control for the patient's condition but don't want to over-sedate them with high-dose opiates to control their pain. So for all of those reasons, these techniques are good to know. I'm going to spend a couple minutes just reviewing the terminology to make sure the vocabulary is clear when I discuss the individual block techniques. Most of the blocks I'm going to be discussing today are done in an in-plane technique versus an out-of-plane. So most of them today are going to be in-plane, meaning that the body of the needle is going to progress parallel to the long axis of the transducer and immediately under the long axis of the transducer, which is going to be a linear transducer for all the indications I'll be discussing today. So in-plane technique is demonstrated here on the left of the screen, and the needle tip and body of the needle are going to progress through the tissues of interest entirely in view under the transducer. In contrast, an out-of-plane technique is what we're all familiar with from placing central lines in the IJ or femoral locations, where the axis of the needle is perpendicular to the long axis of the transducer, and you're going to see essentially just a cross-section of the needle tip show up on the screen at the targeted location. And for the nerve blocks we'll be discussing today, that only comes into play in the posterior tibial block. The majority of them are going to be in plane. I also wanted to take a minute to emphasize how important this spatial setup is for successful placement of a nerve block. I see even experienced practitioners in my setting not taking the time to move the ultrasound across the bed from the provider, and it's really tempting if the ultrasound happens to be on the same side as the injury or the block to leave it where it is and just get going. But it really makes a difference to have it be across the bed from the provider, because some of the movements necessary to maximize needle localization and block success are fairly subtle, and craning your head over your shoulder to look at a screen behind you really does make that much more challenging. So this is not the way to go. Instead, you're going to want to place the ultrasound across the bed from the provider such that the provider's gaze only has to drop a little bit between the ultrasound screen and the skin insertion site for making minor movements to adjust what she's doing in the patient's tissues to reflect where she wants to go on the screen. General contraindications to nerve blocks, and then which are relevant for lower extremity nerve blocks as well, mainly are going to be the skin or soft tissue infection overlying the entry site where you're going to traverse with your needle so that you don't introduce bacteria into deeper structures. That and an allergy to the local anesthetic that you intend to use are the hard contraindications. Certainly if you were otherwise planning to use an amide, you might be able to transfer over to an ester, but if an allergy to the agents involved is a hard contraindication for obvious reasons. And there are going to be a couple relative contraindications as well, and these should really be considered on a case-by-case basis, but they are mentioned throughout the literature, and so I wanted to discuss them. One is that if the patient is altered or uncooperative, that is a relative contraindication. And I say relative because you essentially need a patient who is able to report pain to you that's out of proportion to what you would expect from needle placement alone, which would be suggestive of the idea that you may have actually hit the nerve with the needle tip and may be causing an intraneural injection, which is certainly not what is intended. A patient who has mild dementia or repetitive questioning from their polytrauma with a head trauma component isn't necessarily incapable of reporting the symptoms they're experiencing during a procedure, and in some cases those are patients for whom a nerve block would be a really good idea because you want to monitor their neurologic status and don't want to oversedate them with opiates alone. So it's a relative contraindication, has to be considered on a case-by-case basis. The same is true of bleeding diatheses or patients on Coumadin. The more comfortable you are with nerve blocks, the lower the risk of unintentional vascular damage, although it is never zero. Again, taken on a case-by-case basis. And then a new neurologic deficit. This could include kind of a subtle neuropraxia, which may be due to the fact that they have a fractured or dislocated extremity that you need to reduce in order to improve this situation. I feel like as long as you are carefully documenting the pre-block neurologic exam, this may not be a hard and fast contraindication, but certainly should be discussed with consultant services, including orthopedics. The risks of lower extremity nerve blocks and nerve blocks in general include infection or bleeding, as with any time you violate the skin, and then neuropraxia or peripheral nerve injury, and local anesthetic systemic toxicity. So we'll discuss these latter two, which are specific to this type of procedure, for a second, and then we'll get into some of the individual nerve blocks. So peripheral nerve injury is a rare but not non-existent complication from regional anesthesia and nerve blocks. Unfortunately, the latest kind of reviews on peripheral nerve injury suggest that ultrasound guidance doesn't reduce the risk in quite the same obvious fashion that everybody was hoping for when ultrasound guidance became more widely practiced. However, it's still a good idea. This is a talk, and so everybody's going to be doing these under ultrasound guidance. The ways to reduce the risk of peripheral nerve injury that I can recommend include really knowing the anatomy of the nerve that you're targeting. Nerves in general travel in fascial planes, kind of like a little sleeping bag around the nerve, and you're trying to infuse your anesthetic into that fascial plane in a way where it can diffuse around the nerve and cause a nerve blockade, but you're not trying to inject directly into the nerve or even close enough that you're at risk of direct intraneural injury. So you're going to attempt to enter the fascial plane at some distance from the nerve, but inject anesthetic in a way where it will then subsequently bathe the nerve without causing direct trauma to it. Going to be doing most of these techniques in plane, and so keeping the needle tip in view at all times, and particularly having your needle tip in view before you inject your anesthetic is another way to potentially reduce peripheral nerve injury. And then using a non-cutting needle, of which there are a variety of different types, including Tuohy needles and Whitaker needles. So those are the ways we could try to minimize this risk, but you should also let your patients know in the informed consent process that the risk is not zero. Rare, but not zero. And I feel obligated to mention local anesthetic systemic toxicity, which is the feared, again, rare but feared complication of peripheral nerve blocks and regional anesthesia in general. There are both CNS and cardiovascular effects to local anesthetic systemic toxicity, which I'm going to refer to for the rest of this slide as last, just because otherwise it takes a really long time. These can range from pretty mild effects, such as a metallic taste in the mouth or tinnitus or some lip tingling, up to agitation and seizures. Cardiovascular effects can range again from mild to catastrophic, including bradycardia, AV block, vasodilatation, and hypotension, but up to and including ventricular arrhythmias and cardiovascular collapse. The treatment is intralipid in a 20% fat emulsion. At Highland, where I practice, we do a lot of nerve blocks, and when we really got going with these being a commonly practiced procedure, we talked to pharmacy and nursing and got intralipid in all of our station Pyxis machines such that it was readily available, because you're not going to have the time to go to a different location in a hospital to get intralipid in the event of a catastrophic last reaction. So intralipid is 20% fat emulsion, even though it looks awfully like propofol, and people are tempted to use propofol instead if that's what they have right in front of them, there's not sufficient fat in propofol alone to provide the lipid sink treatment for last. So propofol is not, unfortunately, an appropriate substitute. It has to be this formulation of intralipid. An initial bolus of 1.5 mils per kg is recommended as a starting dose. You can just average that in the heat of the moment to about 100 mils for the average adult. And then you can follow that with a continuous infusion of 0.25 mils per kg per minute until full recovery. If after 30 minutes, which is an awful lot of ACLS coding, you still do not have return of spontaneous circulation, you can redo that initial bolus and then increase the infusion rate after that to 0.5 mg per kg per minute. But ideally, this will not happen. This is the kind of scary, dangerous slide to make sure that everybody is informed of the treatment of this complication, but it is unlikely. So now that I've terrified everybody sufficiently, let's get into the individual blocks. All right, let's talk about the femoral nerve block. I think of all of the blocks I'm going to discuss today, this is the most useful and the highest likelihood to be used outside a trauma setting, because this is the block you would do for hip fractures. And as our population ages, more and more patients are going to come into every type of hospital with hip fractures, and it is a very useful method of providing very good pain control for patients who are typically elderly and sensitive to parenteral treatment for pain. And there's some data that I'm going to be discussing in a couple slides that it really does improve outcome. So block for hip fracture is going to be a frequent indication for this block, as well as for femur fracture. That fracture on the right sure does look uncomfortable. That was a patient that I took care of a couple months ago, and I'll tell you his story soon. Knee and patellar fractures are also covered by this block. And then large abscesses and lacerations of the intermedial thigh are going to be blocked by the femoral nerve block. So the far lateral is not going to be covered, and I'll explain why in a second. So the femoral nerve takes off from the anterior lumbar plexus from L2 to L4 and comes out around, as you can see here, the psoas muscle, and then peaks out underneath the inguinal crease. And so we are going to be picking it up at the level of the femoral vessels, a view that we're all accustomed to from placement of central lines, where we are going to pick up and block our femoral nerve. So I include this slide to indicate that the femoral nerve at this level has already separated from the obturator nerve and the lateral femoral cutaneous nerve, and that explains why its cutaneous innervation or laceration, closure, or abscess IND is going to be separate in the areas not covered by those other nerves. So this is the cutaneous innervation, an area that's going to be blocked by a femoral nerve block at the inguinal level. So the lateral border here is supplied by the lateral femoral cutaneous nerve, and it's not blocked. We've had a couple patients come in who've been working with table saws or other kind of high velocity cutting apparatuses, and they've had large lacerations to the anterior medial thigh, where we've performed this block for proper washout and closure, because the extent of the injury was such that it really was not going to be appropriately anesthetized with local injection alone, which would have been basically a toxic dosing to get a laceration that large anesthetized. The surface anatomy here is demonstrated in these photos. You're basically going to place your transducer as if you were initially looking in transverse fashion at the femoral vessels. So the probe marker is going to be lateral, patient's right, and you're going to initially get the vessels in view, and to lateral to the vein that you're accustomed to looking at for femoral line placement is going to be the artery, and lateral to that artery is going to be the femoral nerve and some associated other tissues. So again, probe marker to the right, and you're going to be doing this block in plane as demonstrated here on the lower portion of the screen, with the needle aiming immediately under and parallel to the long axis of the transducer, such that the needle and needle tip are visualized throughout the procedure. And here's what that is going to then look like on ultrasound. So you're going to have the femoral nerve medially, the femoral nerve artery lateral to that, And then the femoral nerve and some fat and other tissues are going to be within that triangle. So that entire triangle isn't nerve, but the nerve lives within that triangle that's made by the tissue layers lateral to the femoral artery. And I'm going to point out here the overlying fascial layer that is superficial to the femoral nerve and then tracks out horizontally there. It's a kind of a bright white line that I'm going to show you in a couple different videos, and you're going to get pretty accustomed to seeing the more you do this. That is actually the target of this block, is to get under the fascia iliaca. So the goal of needle tip placement here is to not get immediately up next to the femoral nerve in that neighborhood of its yellow triangle, but to get the needle tip under the fascia iliaca and inject anesthetic in that location such that it can bathe the femoral nerve in that fascial plane. And immediately under where it says fascia iliaca, there's going to be kind of the iliacus and iliopsoas muscles. This fascia iliaca investment layer is over that muscle, but also the femoral nerve travels within that fascial layer. So that is the target location. The equipment for this block is a linear probe, as with all the blocks I'm going to be discussing today, and a sterile probe cover, which can, depending on your department's capabilities, can either be a full ultrasound probe cover, such as you would utilize for a central line, or a large tegaderm or opsite over the footprint of the probe that's actually going to be touching the skin. In the emergency department, we're doing single-time blocks. We're not going to be leaving catheters in place, and so covering the whole footprint surface of the probe with tegaderm or opsite is likely sufficient for infection control. Every hospital has their own policies, however. And then most patients are going to require the use of a spinal needle for appropriate depth. So a standard adult 3/9 spinal needle, 20 to 22 gauge, and a non-cutting needle such as a 2E needle. A control syringe can be utilized if you are doing this procedure entirely by yourself without anybody in the room, because that gives you control over the injection of the anesthetic. However, a more straightforward way to do this that gives you a little bit more control over the needle placement is to attach tubing to the end of the spinal needle and then anesthetic at the end of that, pre-flushed before you inject. And that allows you as the block practitioner to place the needle tip exactly where you want it to be in this and hold it there while a second provider, which could be a nurse assisting you with the procedure, injects the local anesthetic. And then a sterile prep and drape. For this particular procedure, you're going to use about 20 to 30 cc's of anesthetic, such as 0.5% bupivacaine or ropivacaine if you choose to use that. So here's that unfortunate patient with his large displaced femur fracture. He was a 25-year-old gentleman who was in a motorcycle collision. And here you can see, again, the vein, the artery, and then this triangle contains the femoral nerve. So the femoral nerve is probably this portion of it down here, and then there's some fat surrounding it. But if you are beginning to look at this area of the anatomy, that's how you identify it as this kind of hyperechoic bright white triangle, and within that triangle is going to be the femoral nerve. And then over here is going to be his fascia iliaca, and we're going to get our needle tip underneath the fascia iliaca to properly anesthetize him. Here we aimed the probe down a little bit, and the artery bifurcated. I'm going to show that one more time. See the needle coming down here. There's the needle tip. And in the next video, you're going to see injection of some anesthetic. Again, we're not trying to get right up into the nerve here. We're trying to get under the fascia iliaca. Here we are a little bit within the muscle belly, and we're going to pop in through to the fascial layer and inject the hypoechoic local anesthetic under that fascia iliaca. And then that's going to diffuse ultimately around the femoral nerve and provide good pain control. That particular patient, the 25-year-old with that fractured femur, was in a tremendous amount of pain and then received a large amount of dilaudid at that point. He was in a motorcycle collision and they were observing him for other trauma as well, and so having him be interactive and report other signs and symptoms of other trauma was to his benefit, but he was in a tremendous amount of pain, and this block provided him really good pain control because he didn't go to the OR for about another 4 hours after that with orthopedics. And in another case, this is a 29-year-old gentleman who was working with heavy machinery, and a large piece of machinery fell onto his pelvis, causing these obvious painful fractures here. Here you see his artery, the area containing his nerve, fascia iliaca there. And artery, nerve, fascia iliaca. I'm going to move this out of the way. Okay. So artery, nerve, fascia iliaca. Here you're going to see the bright white needle coming in, and you see that's the needle tip, and I paused it here to emphasize, so this is the fascia iliaca here, and that needle tip is going to just pop through that layer, and it can end right around here so that it doesn't enter into the body of the muscle belly, but also doesn't need to come right up against the majority of the nerve to infuse the anesthetic. Here, they're about to show you the needle tip. The needle tip is there, and they're infusing hypoechoic appearance of local anesthetic, and you can see it start to push down the nerve here. Infusing more anesthetic, and that's kind of separating out this plane, and then the nerve kind of separates out from the other components of that original triangle, mostly fat. And then there's femoral artery here. So that patient got very good pain control from this block. A bit more infusion of that local anesthetic. So artery, nerve, fascia iliaca, in plane technique, following the needle tip the whole time. Needle tip just under that fascia iliaca, which is sometimes you can feel the penetration of that fascia as a pop. And when this was previously nerve blocks such as this and the fascia iliaca block were done in a landmark-based technique, the description of feeling the two pops of the fascia lata and fascia iliaca were described as a means of knowing that you were in the right location. All right, so that is how you do a femoral nerve block, and I've been referring to it as a femoral nerve block and not a 3-in-1 block, but that is out there in the literature, and so I wanted to address what that means, and is that different than what I'm telling you to do? And the answer is not really. The 3-in-1 is the idea that you could get proximal spread of the anesthetic from the femoral nerve at the inguinal crease, where I showed you on that anatomic drawing that it popped out underneath, to include the lateral femoral cutaneous nerve and obturator nerves for denser, broader block. And the techniques for this include having an assistant place distal pressure, approximately 2 to 4 centimeters distal on the skin to where the anesthetist is infusing the local anesthetic, and placing the patient in Trendelenburg to encourage that local anesthetic to then kind of move up that fascial sheath northward to get the takeoff of the lateral femoral cutaneous and obturator nerves. And it's not clear entirely that this technique works, and for the indications that I'm describing, which is reducing pain for hip fractures and femur fractures and other things in the acutely injured setting, that's likely not required. The time that would make a really big difference is if you're trying to sew up a large laceration on the lateral border of the thigh, in which case you could attempt to employ these techniques to get broader coverage. Similarly, what is a fascia iliaca block in relation to a femoral nerve block? Well, they're going to be supplying the same areas, the same injuries are covered by both. But this is essentially an alternative target for femoral nerve distribution, and it comes out of the landmark-based regional anesthesia days. We are going to be, for obvious reasons, doing this under ultrasound guidance. But this target is just slightly further from the nerve, laterally speaking. And because you are going to be targeting the fascial plane further from the nerve, if you see this described in the literature, you have a program at your hospital for doing this for hip fractures, which is becoming more common, that people have block programs specifically for hip fractures that they develop in consultation with orthopedics. You're going to use 40 cc's of 0.25% ropivacaine. And the difference is I still recommend doing this with the probe marker in the transverse location as you would for a traditional femoral nerve block, but you're going to locate the nerve and then just move further laterally, approximately 2 centimeters, and inject over the dome of the iliacus. So the whole neighborhood of your block moves laterally. Some practitioners recommend at that point, once you localize the fascia iliaca lateral to the nerve, aiming the probe towards the umbilicus. So you may see that out there. That's not the approach that I take. I continue to leave the probe in the original position. So I'll just describe an indication for that here and to show you one of those videos. This is a 67-year-old who had a ground level fall with a femoral neck fracture here. And this is courtesy of my friend and colleague, Dr. Brita Zaya. Here again, you're going to see the fascia iliaca, and then here's her needle tip popping through. The iliacus is demonstrated here, and you're going to see hypoechoic or anechoic spread of local anesthetic, and that kind of pushes this down, and you're under the fascia iliaca here, and then so she's opening up what was previously essentially a potential space in this fascial plane, such that the nerve then eventually becomes blocked when the anesthetic diffuses around it. I want to take just a moment to address hip fractures because this is one of the settings that, as I said, in which many people who are not working at trauma centers are going to be interested in and called upon to perform these blocks. There's a wealth of literature out there, more and more of it in the emergency department setting and under ultrasound guidance, supporting the use of the femoral nerve block in hip fractures. In some, there's a somewhat variability in the literature. Sometimes it's described as a 3-in-1 or fascia iliaca block. Either way, the femoral nerve is getting blocked as part of that. It is pretty clear at this point from this literature that pain scores are improved with use of this block in the hip fracture setting, while concomitantly decreasing the total opioid volume or milligrams needed to control pain. And there's some literature suggestive of the idea that in this population, which is a typically older population at risk for delirium in the hospital setting, that it may decrease delirium through provision of good multimodal non-opiate-based pain control. All right, so that is the femoral nerve, which is one of my favorite blocks to do and probably one of the best for a relatively novice block practitioner. But let's move on to some other indications that you'll need for other injuries, such as the distal sciatic block, also known as the POP block. Indications for this block are going to be predominantly ankle fractures and dislocations. So I'm going to emphasize here distal tib-fib fractures, or we'll just call them ankle fractures. I didn't speak previously about the risk of compartment syndrome and whether or not nerve blocks interfere with the ability to detect burgeoning compartment syndrome by removing the onset of pain or the report of pain, which is one of the earliest indicators for compartment syndrome. But I will say that even kind of the most block prolific of the practitioners at my institution don't like blocking midshaft tib-fib fractures. Those are high energy injuries, and those are at most risk of compartment syndrome, and those we stay away from. So here I'm going to emphasize that this is for ankle fractures that are not in a mechanism not particularly at risk for compartment syndrome, or dislocations, as well as Achilles tendon rupture or lacerations or abscesses to the lateral skin. So because the medial is supplied by the saphenous, which we will address in a little bit. So here we're going to be talking about the sciatic plexus, so L4 to S3. The distal sciatic nerve is going to be targeted here where the tibial nerve and the common peroneal nerve are joined. So the sciatic can branch into those two individual nerves at a variety of different locations in the posterior thigh. The average is about 7 to 10 centimeters north of the popliteal fossa. Again, the distribution is going to be the bones of the ankle, but from a cutaneous perspective, it's going to be the lateral surface of the calf. It wraps around approximately the same distribution posteriorly as well, but it's going to spare the medial surface, including the skin over the medial mound. This block is much easier to do in a prone position than supine, but you may have a patient that has other injuries and therefore may be in a C-collar and can't move into a prone position. In that instance, in both settings, you're going to prop up the distal portion of the leg on whatever you have available. There are never pillows available in my emergency department, so probably on a big pile of blankets. If this is an isolated injury, prone positioning is preferred. Supine, you're just going to have to be holding the probe underneath the thigh rather than kind of letting it rest on it, so it's a little bit more challenging, but certainly still doable. As I said, the sciatic branches in a variety of different locations into the tibial and common peroneal nerves, but starting, it's likely to be at approximately 7 to 10 centimeters above the pop fossa. And I tend to find the distal sciatic by starting in the popliteal fossa and doing the traditional view for DVT compression ultrasound and looking at the vasculature that way, and then isolating the tibial nerve, and then tracing that cephalus that is joined laterally by the peroneal nerve into the distal sciatic, because the sciatic itself is somewhat difficult initially to tell from the surrounding tissues. It is a good example of anisotropy, where the angle at which you angle your ultrasound with the same skin footprint changes the visibility of that nerve. Aiming it slightly distally after you see the two merging can help bring that nerve into a brighter appearance and make it easier to target for a block. And then you're going to use the depth markers on your screen to know how far down that nerve is, and they're going to be entering approximately that far down laterally and coming in at a nearly horizontal angle for the targeting of that nerve. So here's what that looks like from a surface anatomy perspective. This was a friend and colleague of mine named Dr. Chris Childs performing a block in a multiply injured patient for ankle fracture dislocation. You can kind of get a hint there in the back that the patient's in C-collar, which was the reason he had to be supine. So he's propped up distally, and then Chris is holding the probe underneath his thigh and entering nearly horizontally and in plane to target the sciatic nerve. Equipment is much the same as used for the femoral block. Sterile probe cover, opsite, again a spinal needle, and then here you're going to be using approximately 20 cc's of anesthetic. This is what the distal sciatic looks like in those tissues. This is a case of a 22-year-old motorcyclist who was hit by a car. Obvious mortise widening and fractures here. And here's what his sciatic nerve looked like, and then here's what his block looks like. It's here you're going to see the needle tip coming in from the tissues. With the needle tip fully in view, they start to inject hypoechoic local anesthetic. And here you're going to see, this is the sciatic nerve here. They're going to check to see that that anesthetic has diffused around the nerve fully. Because you're coming in horizontally, you can inject anesthetic that can travel above and below the nerve. And then it's helpful to kind of track up and down here. They're going to track distally and then come back up to see that the anesthetic is fully surrounding the nerve and in that plane that contains the nerve, to get a good indication that this is going to fully block that nerve. It's a case of another ankle fracture that required a reduction. This is a case that I took care of, and this was on a day where the emergency department was very, very full, She was actually, this was her only injury. She tripped over her dog's leash and fell down a number of stairs and sustained this fracture. And it was going to be very difficult, a very long delay to get her into the main emergency department in a procedural sedation room for the reduction and splinting of this injury. And so we actually performed her block in the supine beds of our kind of lower acuity beds in the emergency department, such that she didn't need to get moved up to the high acuity procedure rooms. And she got complete anesthesia, and her block was then performed, her reduction and splinting was performed just under the block alone. So here you can see the sciatic nerve. I'm going to play that again. You can actually see the distal components, the tibial and the peroneal, meeting to join the sciatic here. It's a good demonstration of the appearance of that anatomy on ultrasound. And here you can see the bright white needle coming in, needle tip here. This is really right at the level where they're joining, because depending on how much we fan here, you can see they look like separate nerves. Needle right under, hypoechoic local anesthetic coming in under that nerve. And needle tip, injection. A similar case here, this was a woman who fell off a curb and sustained this fracture on the 4th of July. I work at a trauma center in Oakland, and all of our rooms were completely full of patients with firework-related injuries and other injuries related to the holiday, and it was going to be a long delay to getting procedural sedation. And she didn't have any other injuries and was comfortable if she didn't move, but certainly a reduction was going to be very, very painful for her. We performed the nerve block that I'm about to show you. She got complete anesthesia. She got a reduction. The initial reduction didn't work. It didn't provide sufficient alignment. All of her splinting got taken off, and then she got re-reduced under the same initial block. So she didn't have to go back to a procedural sedation room or get any other further intervention. So it was a big win for the patient and the department in that scenario. Here you can see needle, sciatic nerve here, and then there's hypoechoic fluid around that sciatic nerve. All right. So now we're going to round out with the posterior tibial block and the saphenous, and then we'll have a little bit of time for questions. So the posterior tibial block is a block of the tibial nerve at the ankle, where it runs along the posterior tibial artery. So those terms kind of get a little bit conflated, and we just refer to it as a posterior tibial block. The indications for this procedure are lacerations to the sole of the foot and foreign bodies, which are really challenging. The patient's frustrated and the provider can be frustrated because the sole of the foot doesn't absorb local anesthetic very well. It's difficult to locally anesthetize, so it's nice to be able to get the whole sole of the foot there and soak laceration. And then calcaneus fractures are among the most painful fractures, and blocking at the ankle provides good relief for those fractures. The cutaneous innervation here provided by the tibial is going to be the majority of the sole of the foot, but I just want to remind people it's not going to include these portions demonstrated in green here, which are supplied by the sural and saphenous nerves, respectively. The surface anatomy is you're going to be looking for the medial malleolus and then tracing up with the probe such that you can identify the artery. Traditionally speaking, the artery is anterior to the nerve in anatomy textbooks, but in other anatomic investigations where they look at a variety of different angles, there is a somewhat variable location of the nerve relative to the artery, which is why ultrasound guidance can provide a lot of help in localization. This procedure can be done either in or out of plane. Out of plane means that you're, in plane means that you're going to be coming from behind, really nearly at the level of the Achilles tendon, so you're going to need to prop the ankle up in that setting so that you're not dropping down into the bed with the backside of the needle. An in-plane technique is demonstrated here, where you're going to come in as if you're doing a central line and the needle tip comes into view in a transverse fashion. The equipment for this, because it is kind of a smaller real estate, you can do this with a 21 to 25 gauge needle. You don't need a spinal needle. And it's easy to do this in a one practitioner technique with a control syringe. And 5 to 10 cc's of anesthetic is all you need. So here I have an anatomic diagram at the top demonstrating that you're going to look for the artery as your easiest to visualize landmark on ultrasound, and then look for the hyperechoic nerve bundle nearby, typically posterior to that artery, and then target that in or out of plane fashion. This is an in-plane technique, an out-of-plane technique here. You can see they're coming transverse to the probe, out of plane, and then the needle tip is going to show up just posterior to the nerve there in that ultrasound image. Here's a video demonstrating artery, nerve, needle tip, and infusion of anesthetic. This is a close-up here of the nerve. It's small, so it's hard to see if you're not used to looking at them. Needle tip, infusion of anesthetic, artery, nerve. All right, and let's wrap up with the Saphenous block so that we have enough time for questions before the end. I mentioned previously when I was talking about the distal sciatic block that the cutaneous intervention spared the medial surface. So this is not a motor block. This is an end branch of the femoral nerve. So it's the femoral nerve kind of includes this. This is a terminal branch, cutaneous only, and so its predominant indication is the large lacerations or abscesses to the medial calf, medial thigh, or over the malleolus. Cutaneous distribution medially, again, mapped out here. Equipment for this much the same as with the ankle block. A small needle, 21 to 25 gauge. You can certainly use a spinal needle, but you probably don't need that whole length. And about 10 cc's of anesthetic. So the surface anatomy is demonstrated here. You're going to have the patient externally rotate at the hip if their injury permits. Again, you're usually doing this for a skin indication. And then the probe is placed transverse to the axis of the femur there, and then you can move up and down that medial thigh looking for the fascial plane between the vastus medialis and the sartorius, and I'll demonstrate that on the next slide. This is again going to be done in an in-plane fashion, such as is demonstrated here. So the anatomy of the Saphenous block is slightly trickier than the other ones because your landmarks aren't as good for surrounding structures. With all of the previous blocks that I've mentioned, you can start somewhere near a vessel and find an associated nerve, and then in the case of the sciatic, you trace it up so that it's nerve only where the tibial and common peroneal join. And the femoral obviously is adjacent to the femoral artery, and that is true also of the ankle. Here, you're going to be targeting an area between two muscles, a fascial plane between two muscles. There will sometimes be a branch of the femoral artery within it as well, but you're mainly going to be looking for this fascial plane in between these two muscles. So you have the sartorius medially, the vastus medialis laterally, and you're going to be targeting this area for infusion of anesthetic in the fascial plane. And that's what this looks like here. In-plane needle technique, popping under this fascia of the sartorius and infusing locally anesthetic. This is also referred to as a subsartorial block for that exact reason. So while doing your anatomic scan of the medial thigh, you can try to identify these muscle bellies and then that fascial plane, and your target for popping under with your needle tip is going to be the fascial plane that includes the sartorius. All right, so for all of these blocks, it's really important to consider post-block care and communication both with the patient, their caregiver, and consultant services. We at Highland actually mark physically on the patient. with a skin marker, the block performed, the date, and the time. And of course, every which way in the medical record, you document the mechanism, the block performed, and the total volume of anesthetic given to the patient. But we just have seen that patients go to the floor, people are not necessarily reviewing the emergency department record, and they don't know why the patient on their neurocheck isn't moving their lower extremity after getting a femoral nerve block. So marking it directly on the patient, telling the patient certainly if they're capable of reporting, but we find marking it on the patient is also helpful. And then depending on where your institution is in frequency of block performance, it's just really important to have very clear communication with your consultants. Are they okay with a block being performed, and are they going to make sure that they're aware of the length of the anesthesia associated with it? In general, certainly where I work, the orthopedic service is very appreciative of these blocks. They ask for these blocks in hip fractures and femur fractures, and they really see the positive outcome down the road for these patients who receive kind of early multimodal pain control in the emergency department. But it's really important just to be crystal clear with the services that are going to go on and take care of these patients that a block has been performed. And then if you are doing it for a cutaneous reason, but you do something like a PT block where you also get a loss of motor function and the patient is going to go home after their sole of the foot laceration is closed, it is probably to their benefit for you to splint them just so that they don't get additional injury from the fact that they've had a motor blockade. I wanted to thank a number of my colleagues, including Dr. Arun Nagdev and Andrew Herring, who work with me at Highland and are highly expert block performers, and you can see a lot of our information on our website at highlandultrasound.com. I have absolutely no financial involvement. There is no finances emanate from that. It's just informational and educational. And so now I believe we're going to go on to some questions. And I'm going to call up Keynote just in case I need to show you individual pictures. So one, I'm going to see here. Where is the indicator when you're blocking the left leg? So the language around this is always confusing. This is a question regarding where do you put the probe marker when you're blocking the left leg for a femoral block. I still leave it to the patient's right. So whenever I'm performing any sort of ultrasound guided procedure, I want left on the screen to be left as regards my approach to my hand. So if my hand moves left, I want that to be left on the screen. So I leave the probe marker to the patient's right. It is, that is one of the hardest things to explain verbally when I've given this talk and many other variants regarding ultrasound-guided procedures. So left on the screen should be left in life. If your hand moves left with your ultrasound, with your needle tip, that should be left on the screen. And depending on, in general, that leaves the probe marker to the patient's right regardless. Next question. Regarding your example, a femoral nerve block for midshaft femur fractures, our orthopedic docs don't like nerve blocks because they say they can't evaluate for compartment syndrome. How do you deal with this issue? So that is definitely come up for us as well, and it's one of the only reasons that we sometimes hold off on doing blocks is if the orthopedic service says no, they feel like there's a supremely high mechanism of injury, a motorcycle injury at 90 miles an hour, and they want to monitor for compartment syndrome. So the risk is it's small that you're going to miss compartment syndrome by providing a nerve block. However, since compartment syndrome in and of itself isn't incredibly frequent, the idea of decreasing the ability to detect it is very challenging for people. So I think I mentioned perhaps after you wrote this question that we don't do it for tib-fib fractures because of that risk. In our conversations with our orthopedic colleagues, we've just mentioned that there essentially hasn't been literature supporting the idea that we're missing a lot of compartment fractures. compartment syndromes based on doing this, but again, they're going to be taking care of the patient on the floor, so you ultimately have to kind of come to a joint conclusion. If they don't want you to do it, you don't do it. The next question is how much volume of anesthetic? So that depends on the block. So for the femoral block, 20 to 30 cc's. A fascia iliaca is going to be a larger total volume, although the concentration then drops, and that's so that can diffuse over a larger distance. So that would be 40 cc's of 0.25%. Ropivacaine is one of the things we use most frequently for that. Sciatic is going to be 20. Posterior tibial is going to be 5 to 10, and saphenous is 10. What kind of anesthetics do you prefer to use? So in general, these are highly painful conditions that are not about to disappear. So I tend to use ropivacaine or bupivacaine for most of them. Let's see. Oh, thank you from Ireland. Oh, I appreciate that. Thank you. My question pertains to evaluating the patient's neurologic status post-reduction when you have blocked the patient. Did the ortho service push back when your program began to do blocks because of inability to follow neurostatus post-reduction? Also, do they prefer shorter-acting agents versus longer-acting agents? That is an excellent, excellent question. So some of it is injury dependent. So for ankle fractures, the chances of there being a neuropraxia from the reduction of those distal fibular fractures is pretty small. The example of using a shorter acting agent so that you can track the neurostatus afterwards is a really good one. So if it's an ankle fracture, reducing it and splinting it is going to provide good pain control once the actual reduction is done. Using lidocaine in that setting would be could provide you kind of a more rapid return to a baseline neurostatus. However, I mean, most of those patients get discharged. So after the reduction, I guess they get an immediate neurocheck, but most of those patients, if they don't have other sources of injuries, are going to go home. Our ortho service didn't push back about those types of injuries. It's more the conversations we had with them when we started doing more blocks was more pertinent to compartment syndrome, which was the excellent earlier question there. Given potential risk of cardiotoxicity, does your ED mandate use of cardiac monitoring, nursing, and timeout, et cetera, like in the standard procedural sedation? So it's one of the reasons we changed, or didn't change, but it's one of the great features of ropivacaine as opposed to bupivacaine, is less cardiotoxic but has a similar long duration of action for hip fracture patients and patients where it's an ongoing painful injury. It's going to be painful when they go up on the floor, so you want it to last for a long time, not just, again, for like a short reduction or laceration closure. So our emergency department does not mandate the use of cardiac monitoring for ropivacaine, but some places, in a different practice setting where I used to work, when they kind of brought out, this was their first initial block program where they were kind of bringing blocks to the frontier and people were not familiar with it. They do have people be one-to-one on cardiac monitor, but they don't necessarily have to be kind of in the intubation room. Every hospital does procedural sedations a little bit differently, but some places it's kind of like a full-on code room and it's hard to get into those rooms for the procedural sedation. Does local infiltration lead to last toxicity, or do you have to inject intra-arterially to see last? What is the last rate at Highland, and which block do you see it more in? So local infiltration, unless you're using a really super therapeutic amount, does not typically lead to last. Last is usually inadvertent vascular injection. I have never actually seen a case of last at Highland, and I'm not sure. I did residency here and before I started working here as faculty. So in all of those years, I have not heard of a kind of an ACLS case of last. There was one suspected case where their lip tingling was mentioned by the patient, and the concern was that that might have been a minor last reaction, but it wasn't entirely clear. How long does the anesthetic effect last? It depends on the agent. So ropivacaine can last, if you do that in a fascia iliaca block, that can last up to 8 hours. Bupivacaine is similar, and then lidocaine would be a shorter acting agent. And what percentage of the time do your nerve blocks fail to achieve the desired anesthesia? And this will be the last question because I think we just crossed into 11 o'clock. That's hard to say. So they don't work if you don't get the anesthetic in the appropriate fascial plane. We're also, I hate to say it so bluntly, but we are a training program, and so as with any procedure, we're instructing kind of novice providers in this procedure. I would say rarely do they fail outright where people thought they were in the right location. More often, people are saying, I'm not exactly sure if I'm in the correct fascial plane, and kind of a supervisor will help mid-procedure guide to the appropriate location, and then anesthetic is injected. In these particular blocks, when you become comfortable with it, they're highly successful. And I think that will be the last question. Kathy, I don't know if you want to say anything else to wrap us up.
I would just like to thank you very much, Dr. Bailey, for that wonderful presentation, and also thanks to everyone in the audience who participated today. Everyone, please remember to complete the post-test and the activity evaluation. We hope you enjoyed today's presentation and will join us again for future webinars. Bye, everybody. Have a great weekend.